Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center reporting for the week of November 27th, 2023. After a COVID status update, I'll touch on the pneumonia outbreak in China, at-home testing, and a new study on long COVID and the vaccine. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there is still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at wastewater, the gray band over to the far right is the time period that's not fully updated yet. And then the purplish shaded band there are the 2 weeks before that. So those are the most recent completed weeks, kind of shaded in light purple. And those we can see that the red and the orange do appear to be trending upward. Overall, this represents over 1,100 sites nationwide, and about 45% of the sites are reporting increases. About 35% are showing decreases. And this is kind of demonstrated when we look at the map, where we can see that it really is all over the place. The blue dots mean that SARS-CoV-2 concentrations are decreasing, like some areas on the West Coast, and the orange and red means that the concentrations are increasing, and this is over the last 15 days. And we can also see that there's large swaths of the country with no sites reporting in here. And so if you want to know what's going on in your area, take a look at a wastewater site that is near you. There are multiple sources linked in the post. So moving on to percent positivity, unfortunately, we do see that that is ticking up a bit here. And so as of November 11th, we can see that test positivity is 9.9%. So we're almost up to 10% positivity. That's up from 8% the week before. And this is based on more tests than previously. So we're looking at around 86,000, almost 87,000 tests per week being conducted. We would expect that to continue increasing, since people will hopefully be getting tested for any other types of respiratory symptoms they may be having. So we expect the number of tests being done to go up, and we'll just continue to watch the percent positivity. But obviously it was already heading up before going into Thanksgiving holiday. So we'll have to monitor to see what happens over the coming weeks. And unfortunately, taking a look at emergency department visits, this is our most updated indicator. We can see that it is going up. It is lagging a little behind what we've been seeing previously because of the holiday. So this is almost a week old. It's updated through November 21st. Hopefully, reporting will get caught up by the time I do the briefing next week, but this is obviously headed in the wrong direction nonetheless, even before the Thanksgiving holiday weekend. And taking a look at hospitalizations, definitely not happy to see this. So we've got hospitalizations heading back up. We're now over 18,000 hospitalizations for the week ending November 18th. So again, this is before the Thanksgiving holiday weekend. And of course, we expect things to kind of go up from there as increased mixing leads to increased cases and so on. But this is almost triple what we were seeing for most of the month of June. So quite a lot of people every week being admitted for or with COVID. And again, we don't like what appears to be a trend going in the wrong direction. And taking a look at deaths, we've really been around 1,200 deaths every week, essentially for September, October, and what we're seeing so far in November. So that's more than double where we were just this past June and July. So hate to be going in the wrong direction, especially so far before the winter months. So this is still a lot of people dying every week, and we know that many of these deaths could have been prevented with prompt outpatient treatment, and also if they were fully vaccinated. So we need to make sure we're doing those things, especially in people who are in higher risk categories. But really, anyone is susceptible to a potential bad outcome, which is not just limited to death. Of course, this is the most severe outcome, but it's not the only bad outcome. And with 18,000 new hospital admissions a week, we know that people are suffering, organs are being damaged, and of course, some percentage of people are ending up with post-COVID or long COVID issues. And now taking a look at variant proportions, that kind of lilac color over to the far right, that's the BA.2.86. I've been speaking about this for a while, and then it didn't really seem like it was quite taking off, but now we see that it is. It's increasing. It's projected to be almost 9% of specimens, and it's now being declared, well, it was declared a variant under monitoring by the World Health Organization back in August, but which is when I probably started talking about it. And then last week it was reclassified as being a variant of interest because the proportions are growing, not just in the United States, but worldwide. And this includes the JN.1, which is part of this family, but that is still a small, it's less than 1%. So we're not seeing it on this nowcast tracker just yet because that's the threshold when the CDC will put it on the graph, but it is included within the BA.2.86 umbrella. And essentially, we're mostly concerned because it does seem to get around some of our prior immunity. We're still hopeful, and it does look like the boost that you get from the current monovalent booster will provide protection against this. I think what's going to remain to be seen is sort of how it takes off, if it's going to spread. Is it going to drive more cases? Is it going to drive more hospitalizations? We're not sure. We're not quite seeing that yet. The proportions are still a little bit too small here, and we're just going to have to keep an eye on this, not only here in the United States, but worldwide. And flu cases are continuing to increase. We're kind of getting into the swing of the flu season. For the week ending November 18th, we were at 4.9% positive, and that was up from 4% the week before. Over 3,000 hospitalizations that week as well. And that's compared to over 18,000 COVID hospitalizations, but we do expect the burden of the flu to kind of start increasing from here. We've unfortunately had 740 deaths so far this flu season in the United States. 3 of those are sadly pediatric deaths. And also detections of RSV are heading up nationwide, just like they did this time last year. So of course, the concern is always that we've got RSV, we've got flu, we've got COVID, and any and all of these things can lead to potential hospitalizations, potential bad outcomes. Flu and RSV tend to result in bad outcomes, in particular for the extremes of age and also those who are pregnant. So those are the folks we really want to be thinking about protecting with vaccines. So children 5 and under, those 65 and up, as well as those who are pregnant. And the flu vaccine does significantly reduce the risk of a bad outcome. It's recommended for everyone 6 months and up. We do have a new RSV vaccine out, and it is worth speaking with your doctor to see if you can access that, especially for the little ones where this might be their first RSV season, especially if they were born premature, and also folks over 65, as well as our pregnant folks. And this slide is just showing the level of respiratory illness, and this is just for the week ending November 18th. So you can see there's a lot of geographic variability here, and really the high areas are kind of in the south, especially in the southeast there. And so this has to do with people presenting at emergency departments or even some outpatient settings with respiratory symptoms. So this doesn't break down by which one it is, but I think it's helpful sometimes to see the geographic spread. So we'll keep an eye as we get further into respiratory virus season. And speaking of respiratory season, we've got a wave of childhood pneumonia that's being reported out of China. You may have already heard about this in the news. And I think understandably, this has made some folks nervous since it was pretty much around this time 4 years ago when we first started to get the news from China about SARS-CoV-2, which of course turned into a global pandemic. But based on what we're hearing, this outbreak is not that. It's nothing new. It actually appears to be due to a bacterium that is definitely not new. It's called Mycoplasma pneumonia. And it's the most common cause of what you might have heard of being called walking pneumonia, which typically means that you're walking around with pneumonia without even realizing how much of your lungs may be affected. And typically it can be treated on an outpatient basis as well with antibiotics, but it can cause hospitalization, particularly in people without a more developed immune system, which includes younger children. Details about what's going on with this outbreak are kind of trickling in slowly, but it does seem as though it's not only China being affected. There's been some reports of increases in France and South Korea as well. And as I mentioned, those at risk of hospitalization or a poor outcome with mycoplasma pneumonia are those with the less developed immune system or compromised immune system. So this could include young children, this could include those with underlying conditions, and it could also include people who've recently been ill, including people who have had COVID. And another phenomenon we've seen is co-infection with virus and mycoplasma. So it could be COVID or flu with mycoplasma. But once again, we don't have those kind of details about the cases that we're seeing. We really don't even have numbers per se about this particular outbreak. So we will need to await more information. But a couple of things to note here. First is that this type of pneumonia, mycoplasma pneumonia, can be usually fairly simply treated with antibiotics. But one of the reports, unfortunately, we're getting is that China is reporting that they're seeing a fair bit of resistance to these antibiotics. And also, you might recall antibiotic supply and antibiotic resistance have been two issues that have been coming up throughout the pandemic. I reported them here on a few different occasions for some different scenarios. But one thing we saw a lot of, and unfortunately, I'm still hearing stories about this, is doctors prescribing Z-Pak. So Z-Pak is azithromycin. It's very convenient, and sometimes patients ask for it, and doctors should not be prescribing it on demand. This azithromycin is actually an antibiotic that can usually treat mycoplasma pneumonia, but we are seeing resistance, or that's what's being reported from China. And resistance is often a result of overprescribing the antibiotic. And so and then also there have been different supply chain issues, not necessarily with this antibiotic per se, but with other antibiotics, including a current shortage we're having of penicillin G, which also is very concerning. So all of this is to say, first off, I don't think the situation is cause for concern for another pandemic. This is not a novel virus. It is an old bacteria. But I do think we need to take the matter seriously. First off, antibiotic resistance and antibiotic supply are very serious issues that seem to be cropping up lately. It seems as though pharmaceutical companies are not super motivated to come up with new antibiotics for old pathogens, for old bugs. But given the way things seem to be heading, that's likely what we need that's what's needed. The other thing that is needed is more sparing use of antibiotics. We should not be prescribing antibiotics for viruses. If a doctor wants to give you an antibiotic, it's completely fair to ask, what are we treating? Because if we don't have a bacterial infection, then we need to know what is the point of the antibiotic. And these are things that get talked about a lot. There are programs called like antimicrobial stewardship programs in hospitals and so on, so that people are more cautious and not just throwing antibiotics at things because it might be a bacteria, but really being a little bit more nuanced about it. I have heard too many stories of doctors prescribing a Z-Pak for COVID, which is obviously ridiculous since antibiotics are for bacteria, not viruses. And now we see the situation where what's being reported in Beijing is 70 to 90% antibiotic resistance of mycoplasma pneumonia that they are isolating. So that could be contributing to the higher than expected levels of hospitalization they're seeing there in China amongst children with pneumonia. Again, we need to see the results coming out? Are they actually seeing antibiotic resistance in those children, or is this just something more general? And so we're, we're trying not to connect dots that aren't supposed to be connected. But I think for me, in reading this story, these were kind of the items I just wanted to flag for us to think about. But in the meantime, I do wish more details would come out. But I am also grateful to see that there is kind of a public discussion about disease outbreaks in other parts of the world that hopefully can inform us better and keep us better prepared in the event of a more dramatic situation in the future. Next, I want to briefly report on this article that was published last week in BMJ. And this was a large population-based study suggesting that COVID vaccine before COVID infection reduces the risk of long COVID. And this was a large review coming out of Sweden of 589,722 people. So population-based studies. They were kind of looking back at a large swath of the population. And basically what they showed is that the unvaccinated were about 3.5 times more likely to then have long COVID than those who were vaccinated. So these are people who got a COVID infection after having been vaccinated. And the effectiveness against long COVID was higher for each dose, essentially. So the effectiveness after one dose was only about 21%, so better than nothing, but only about 21%. For 2 doses, it was 59%, and for 3 or more doses, it was 73% reduction. So that's pretty significant. And if you kind of take it across the board, for any dose given before a COVID infection, the vaccine effectiveness against long COVID was 58%. And just a couple months ago, I reviewed a meta-analysis of 6 different studies that concluded something similar. So it is reassuring to see this more or less replicated. And I linked to that prior briefing in the post in case you wanted to check that out, where I did review not only that study, but also the qualities of a good meta-analysis in case that is of interest. But this particular study, which is not a meta-analysis, it's a population-based study, went a bit further, and it's stratified based on the time between the last vaccine and the COVID infection. So the median time in the study between the last vaccination and the COVID infection was 126 days, so about 4 months. So they took that time, the 126 days, and they looked at the 2 groups kind of separately. So the people who had the vaccine 126 days or more or less from the time that they then got infected. And they found that the vaccine effectiveness against long COVID before infection was a little bit less protective if the duration was longer, which kind of makes sense. So if the duration between the vaccine and the subsequent infection was more than 126 days, then the protection was about 49%, and the protection was higher if the duration was less than 126 days. So if it was a shorter time between the vaccine and the infection, then the protection was higher, so about 63%. So remember I said the overall effectiveness for any dose was 58%. For the group that had vaccine more than 126 days prior to infection, the effectiveness was 49%. So not terrible, but a little bit lower. And for those who had it more recently than the 126 days, the effectiveness was 63%. So pretty good, a bit higher. So overall finding is the same, that vaccine before infection is associated with a lower risk of long COVID, and the vaccine effectiveness against long COVID increases with the increasing number of doses before COVID infection. And there does seem to be some improved effectiveness of having had the vaccine closer to the infection rather than a longer time before. So this information may suggest that vaccination getting a booster is going to provide a little bit more protection against a long COVID. That we don't know that because those just came out, and we'll need more study to really nail that down. But these are kind of what this information suggests. Basically, vaccine before COVID infection is strongly associated with the reduced risk of long COVID. It still tells us nothing about those who already have long COVID. Unfortunately, we still have a lot of work to do in that area. And next, I want to provide you with this reminder that in the United States, you can order your free test from the government. This program reopened on November 20th for you to get 4 more free tests delivered to you. Also, for those who are uninsured or underinsured, there should be locations near you that are distributing free tests, including public health departments, public health clinics, community clinics. We are continuing to distribute them at Roots Community Health Center in Oakland and San Jose, along with KN95 masks. In my ideal world, these would be free to everyone all the time, since this is a situation we're all in. And honestly, the pricing of these tests is truly ridiculous. But here we are, and at least you can order your 4 free tests. So please go ahead and take advantage of that. And as a reminder, why test? Well, first off, we want to break the chains of transmission, and we can only do that if we know who has it, and so that we can keep them from spreading it to others. And certainly, currently, after this holiday weekend, I think we would be wise and also considerate to test before returning to work and school. If everyone did this, we would break a lot of these chains of transmission. And of course, if you turn up positive, please stay home and rest and give everybody a call that you saw over the holiday weekend, or really, within the preceding 7 days or so. So that they can isolate and also access timely treatment if needed. Which brings me to another big reason for testing, which is for timely outpatient treatment so that you don't end up being one of those 1,200 people per week that's dying from COVID, or one of the 18,000 people hospitalized. And also so that you can warn others so that they can get timely outpatient treatment and not end up being one of those people as well. And also so that you can isolate from others and not spread it around. You can do what you can to prevent household spread. We're hearing a lot of success in people taking measures to prevent it spreading even within their own homes. And then also you can test so that you'll know when it's safe to exit isolation. And then last but definitely not least, you can test before getting together with others to add another layer of protection for a COVID safer gathering. So pre-event testing. And COVID is still with us. It is still causing sickness, disability, and death, and there is still a lot we don't know. And the season for influenza and RSV is just getting underway. And there's some pneumonia going on that has not hit us here in the United States, but I think in general, it's just a word of caution. This is the winter time. And, a lot of the infections that we've seen historically, their seasons have been thrown off by everything else that's been going on. And so I just wouldn't want to take anything for granted. I would just assume that the protections that we do for RSV, flu, and COVID are also going to protect from others like pneumonia. So let's just keep up our best practices to prevent the spread of all respiratory illnesses and to prevent outbreaks. Remember, no one layer is foolproof, so the more layers, the better. Following COVID, we are seeing increased risk of impacts on almost any organ system. We are seeing new onset diabetes, we're seeing heart attacks and strokes, memory issues, worsening asthma, and so on. Of course, this is not in everyone and it's not with every infection, but it could happen after the first infection, but maybe not until the second, third, or fourth. There's just no way to predict these things and no way to predict who this is going to really impact, at least not yet. And so catching COVID once and doing fine is not a guarantee about the next time. And every infection is a new opportunity and perhaps even a compounded opportunity for long COVID and post-COVID impacts. Remember, if you do not have a primary care provider, please get one. Know how to reach them before you need them. And get your blood pressure checked, your baseline labs checked, like sugar and cholesterol and vitamin D. Consider taking a multivitamin supplement. Get some regular physical activity, unless, of course, you're sick. In that case, please get your rest. And as always, do what you can to manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. We will see you next Tuesday at 10 a.m.